So if anybody, there are microphones in the middle. If you have comments, questions, this is your time. Tammy.
Hi, thanks. I'm Tammy Rowan. I'm at UCSF. I'm a gynecologist. And one of the things that I see, I take care of many of the women at our institution with cancer, is the women who seem to be having the hardest time are those who do not have a regular partner, those who are interested in having a partner, those who maybe haven't been sexually active and then have been diagnosed with cancer. And I feel like we, in this session, talked a lot about those with partners, how to get those partners in, but I want to talk about those women who don't have a current one but would like one, and I would love to get your thoughts and perspectives on how you counsel them, how you know, what things we should be thinking about for them.
Can I make a comment first? I think it's a really important issue, so thank you for raising it. And I think it's a particular issue we found with the AYA, so the adults and adolescents and young adults. And I think particularly for people who've never had a relationship before cancer, and the whole issue of disclosing cancer diagnosis or potentially exposing a body that might have physical changes to it, I think is a really major issue, and I think can be a cause of incredible distress. So I think it's very important to be taken on board. And I think also for people who are not in relationships, who may have had a previous relationship, the cancer may have ended their relationship, or they may be not in a relationship when they get cancer. There can be a lot of anxiety about future relationships. And we also know that they're a group of people that are less likely to get any information about sexuality from healthcare professionals who think because they're single they're not having sex, which we know isn't true. So I'll pass over to the clinician to what to do about it.
It's a tricky situation, and one of the questions I get asked all the time is, when should I tell someone? They're like, it's such a big part of me, and you know, you don't want to go on the first date and be like, by the way, I had cancer, I'm on this treatment, I don't have breasts. But we tell people within like the first 3 dates they should mention it, because it is such a big part of who they are. And if someone's not going to want to be with them, you don't want their relationship to go on or them to get too attached to someone before, and then the person be like, oh, I can't be with a cancer survivor. Because I've had patients be like, as soon as I told this person, they just turned off and they can't be with me. So usually I say around date 3 they should mention it, because if you wait too long, it's such a big part of you and who you are that you're holding back and they're not really getting to know yourself. And we have workshops actually on how to talk to people about this, how to disclose that you're a cancer patient or cancer survivor. And we have social workers who do workshops with people, and we practice in clinic. They practice telling us. But I always encourage people to tell their partner or the person they're dating sooner rather than later, because you're a cancer survivor, it's who you are. And if you're waiting till you're dating someone for months and then you start telling them, they feel like you've held back.
Thank you.
I would just add maybe one thing to that too, and that is that there's a lot of research that demonstrates that people's symptom burden can be one of the barriers to even thinking about it. And so kind of getting back to what Jane said, that a lot of people sort of rationalize, well, I'm older anyway, it doesn't matter. And some people say, well, it doesn't matter that I have a dry vagina or that I don't have any interest or I'm too pooped to even do anything to think about it because I don't have a partner and who cares. And I think, really opening the door with those people, and even if somebody responds to that open-ended question that Sherry talked about, do you have any sexual concerns? If somebody said, no, I don't have any sexual concerns because I don't have a partner, I think that's a perfect opportunity to say, that doesn't mean that you won't ever want one or ever want to think of yourself as a sexual being, or in what ways might you feel that disembodiment. So still helping people deal with those concrete foundational issues may change their future perspective on what they even want in their lives. And so I guess what I'm saying is not helping people not write themselves off for various reasons.
I just wanted to make a quick comment about that, Leslie Shover from Houston. A lot of people don't realize that half of American women over age 50 are sexually inactive, either because they don't have a partner or their partner's not sexually functional. And even in this day and age, it's often the men's sexual function that determines whether a couple stays active. And I'd also point out that, so there's a a big discrepancy in the dating market between older women and men. And I would also point out that I have a lot of older men who would say to me, well, I have erectile dysfunction, so I can't date. And I often point out to them that they are the lucky ones because they're in the buyer's market. And there's going to be a lot of women who are interested in a lot of aspects of relationships and dating, and not just whether they have a hard erection. So.
Thank you. Any other comments, questions, thoughts? Anything that keeps you up at night? Related to this topic, of course.
Deb, I've got a comment, and at the risk of being controversial here, I guess what was running through my mind when particularly, when Shari was talking about the lack of time to talk about sexuality, I don't disagree that sexuality is extremely important. But if you go to a complementary and alternative therapy session, always it's, we really need to bring this up in the consultation, but there's not enough time. If you go to a carers session, it's always brought up, we really need to bring up the concerns of carers. If you go to a psychosocial session, we really need to explore whether or not the patient is anxious and depressed. And I guess that I don't know what the answer to this is, but any particular topic, of course there are really important reasons for bringing it up, and it is only a 15-minute consultation. And I guess that I'm putting it back to the clinicians, or maybe another member of the audience, how do we actually balance all of these legitimately, important concerns, and it's only in a 15-minute consultation?
Well, I think, one thing to do, as I started to say, is I think talking to people when you have the initial consultation and talk about the side effects of treatment, I always bring up that you're going to have sexual complications, whether it's vaginal dryness, decreased libido. And then instead of just not bringing it up until people are done with treatment, I think it helps to sort of ask about it along the way. And in follow-up, while you're sure that most people don't even discuss this in follow-up, it's more likely to be brought up at the beginning in the first conversation. I think it's easier when someone's coming back after treatment and follow-up to sort of bring these topics up, whether it's fertility, sexual health, bone health, in the survivorship setting. And I think also we're lucky that we have Jean Carter runs a women's health clinic and sexual function clinic, so we can refer people. So I think bringing it up, normalizing this, we cause these side effects. Are you interested in getting help? Are you interested in getting treatment? And many people are, and many people won't go on their own, but if you encourage them and refer them to the appropriate people, that helps. But I do think some people want to talk to the doctor who's treating them. So what do you think? I'll get asked this. So what do you think? Do you think I should try this? Do you think this is safe for me? You know my cancer history. I don't want my cancer coming back. Do you think this is safe in the setting that I had an ER-positive breast cancer? And they end up being long discussions. So I do spend time in my clinic appointments discussing this and addressing this all the time because it's an issue that's important to me. But it's really difficult to get even some of my colleagues to address it. And sometimes they send them to me to talk about these things. So I think if people are dedicated and really focused on it, then you can bring it up and you find the time, even if your session runs over or, you bring it up. It's like you have nausea, you're vomiting, you have sexual dysfunction, and you make it normal as part of the conversation. But it's going to be a transition to get a lot of clinicians to start doing this, and we have to educate people.
And I think just to add to that, it isn't an issue, as was said by, I think you said it in your talk, Sherry, that it isn't an issue for all people, but for many people with cancer, it's one of the most significant long-term effects of cancer treatment. And I think for those people, for it not to be mentioned is actually dreadful. And many people in our research across studies have actually said that it's been incredibly traumatic, the impact on their sexuality. So I think it is really important to bring up, to at least open the door if people do want to discuss it.
And in all the Livestrong surveys, sexual dysfunction and sexual complications of cancer treatment are always in the top 3. And it's frequently the top complaint that people have in long-term survivors.
Thank you. Well, on that note, this flashing red light tells us that we are out of time.